sort of decision making in healthcare. And we'll see. I'm kind of throwing a lot in this talk, and the whole area of decision making is, you know, the content could be in courses, not just in 40 minutes. And that 40 minutes is if I don't ramble, so I have to stop rambling. But I'm hoping that there'll be things in here that really you connect with, and I would really like us to have a conversation at the end. Anything that you pick up on, you want to ask questions about. That's why I'm trying to kind of compress what I'm talking about, so we have a bit more of a conversation. So, and thanks for the introduction, Amy. So I'm here because I'm a professor. So I probably started off looking really cool and just got very uncool. I just came across this photo of myself, and I'm so old. You know, they hadn't invented color photography when I was a baby, apparently. But I'm here partly because I've had basically a whole career really around decision making in health and in healthcare of one kind or another. So I'm a doctor. I trained in internal medicine to start with, but I very quickly moved into public health, and public health is really my specialty, my discipline. And what that means is that I have been involved with, you know, hospital settings, but also health authorities, agencies at a kind of a national level and at a more local level. I've been around all kinds of decision making, and have seen the best and the worst of it. But and what I'm talking about is what I've tried to do is draw together, you know, what's the flavor of it, and how do people think about it, and how do decision makers think about it. But it's really, there's a bit of evidence in this, but a lot of it is just drawing on my own experience. So we'll get rid of that photo. So what I'm going to cover is, let's just talk about the kinds of decisions. So you guys are doing this course, infectious disease modeling. You know, you're scientists, you're doing empirical work, you're creating data, and you're creating evidence, or data that can become evidence that can be the basis for decisions, that will go into decisions. But who is using this? What kinds of people use it, and what kind of decisions are they making? And what matters in health policy decision making specifically? I'm going to talk about the context in which the decision making happens, including just how bad we all are intuitively at making decisions sometimes, and draw it together with some thoughts that I hope make some sense to you. So let's just kind of get into that. So who are we talking about, and what kinds of decisions? So first of all, I want to really separate out something very, very basic about, you know, if we're talking about health decisions, first of all, that's a very broad thing. I want to kind of separate out decisions, or things that are meant to inform decisions and decision making in the clinical context. In other words, in the care of individual patients and their families, and how clinical practice should happen. I'm going to talk about that a bit. I'm going to talk more about the second of these, which is the policy perspective, which is more the kind of the higher level decision making, which is about what are our priorities, what are we going to fund, what should we stop doing, how are we going to allocate resources to achieve certain ends, those kinds of things. So this is much more about the policy side, but I think it's really useful to know about that individual clinical decision-making side. And I suspect that maybe for some of you, you've never really separated these. A lot of people never separate these, but the nature of this decision-making is there's a lot of similarities, but there's also very important differences. And I will say, as a starting point, that when we talk about populations and we talk about individuals, a population is a thing in itself. It's not just the sum of all the individuals in it. There's an emergent way of looking at it. So there are differences. So let's kind of start with the first of these. So what am I talking about? So the first thing is to say that there's many different kinds of clinical decisions. So thinking, you know, imagining yourself to be a doctor, trying to help a patient make a decision. Well, the decisions are not all about the same thing. It's not homogenous. They are directed towards different kinds of ends, different kinds of information is needed for these, different kinds of evidence is needed to underpin them. But it's one way that we think about the continuum of what we're doing is from primary prevention, which is actually, pardon me, stopping things before they ever start by getting rid of or mitigating actual risk factors. So if people don't smoke, then all the things that are the consequences of smoking don't happen. So primary prevention is the most upstream thing that we can do. And it is actually of the most concern also in the policy arena. Screening is different. Screening is about going to people who actually think they're healthy and offering them some kind of test to find out, well, do you actually have something you didn't know that you had? So it's the ID of early detection, so that if you do something about it, it will make a difference down the line. For most of clinical care is about investigation and diagnosis. It's about responding to things that are going on that cause concern. Finding out, is there something wrong and what is it? And trying to nail that down. So that's the diagnostic kind of arena. Treatment is about treating diseases. You know, what can we do about this thing? And management is more broadly, how do we overall look after this patient with this condition or in this situation? So it's a kind of a broader idea. Now, I want to talk about guidelines. So all of this, so doctors practice with a considerable amount of autonomy. They use their discretion, they use their judgment. Medicine is an art as well as a science, so it draws on a lot, but it's also a lot kind of has to rest there with the person, the professional. They're kind of sitting on it. But we are very much these days, it's never just that individual kind of having to know everything and, you know, make decisions in a vacuum. That all clinical practice is guided to some extent by best evidence of what to do in a particular situation. So we commonly talk about clinical practice guidelines. We could be talking about recommendations. We could be talking about criteria for doing this, but there's a sort of an infrastructure of a knowledge infrastructure that says, this is what you should be doing for the average patient in this situation. So it's a kind of an average one size fits all, generally speaking. Full disclosure, I've just stepped down after 2 terms of service on the Canadian Task Force for Preventive Healthcare, but they're one of the Canadian organisations that puts together these kind of guidelines for clinical practice. And the focus with these always, or always should start with core scientific evidence. So now, all the way through, I'm using this word evidence kind of loosely, but I'm talking about the science that underpins the things we actually know, the empirical analyses we can do. In most cases, I tend to be referring to systematic reviews, overviews of evidence, meta-analyses, those kinds of things, but it can be primary research of any kind. So I'm hoping that you'll make the connection that you know, modeling is part of this kind of whole spectrum. So I'm just going to use the word evidence to refer to all of that. And the focus is always, firstly, on effectiveness. So, you know, what is the best way of treating this? What's the best way of screening for this? You know, of all the options that are available, what are the ones that actually work? Effectiveness is about what actually works and what doesn't work. And it's also the subject of randomized controlled trials, those kinds of things. That's where we start. Harms as well. Nothing comes for free in terms of, you know, anything that can produce a kind of a good effect often produces other effects as well, and some of those may be undesirable. So you know, and if we go to medical ethics, you know, first do no harm and then do some good. It's kind of how those get articulated. The costs, and we'll talk about costs as we go on, because costs aren't just about, you know, we don't want to spend money. There's much more about costs than that. And feasibility, how you put things into practice, and sometimes about equity. So I'm going to talk about equity as well as we go on. Now, why am I going on about clinical practice guidelines? It's because those underpin, they're the starting point for a lot of clinical decision making for individual patients. And they require evidence. and anybody can put together guidelines, but there's a difference between those that are based on people's opinions and anecdote and those that are based on actual objective assessments of empirical data. And the latter are what we look for. And if you go searching for a guideline on any particular clinical topic, you know, how to treat ingrown toenails, whatever, you'll find lots of guidelines. Actually, you probably won't find any about ingrown toenails, but it's probably not that as important. But how to treat a heart attack, how to prevent stroke, how to deal with someone who you suspect may have dementia. You know, those are really big ticket things. If you go search for guidelines, you will find dozens or hundreds, and they won't necessarily all say the same things. And so there's a whole kind of backup system to this to say, how do we trust a guideline? And we definitely, one of the bits that's really important is, are they based on evidence, and was the evidence put together in a way that is credible? So AGREE is one of the kind of the big entities that's actually moved this forward to articulate what makes for good evidence in a guideline. So appraisal of guidelines for research and evaluation, that's where the acronym comes from. And I pulled out just really quickly one part of the current AGREE tool that's used. So you can go to any published guideline and you can try to then find out about how did they put it together, and you can rate it. And so there are ways of rating credible guidelines versus less credible guidelines. And one central part of that is what evidence was used, how did people find it, how did they judge it, how did they put it together? So when you hear people talking about evidence-based medicine, for example, evidence-based healthcare, this is what they're really talking about. And so guidelines are statements about what we should be doing. However, when it comes all the way down to the individual patient, so back to that encounter, it is really not a simple process, because when people make decisions about their health, there's a lot more will play into it. And so you see some of these themes will come into policy decision making as well, that preferences and values, tolerance for risk, you have to meet people where they're at. Now, so for this slide, I pulled it off Alberta Health Services website. I could have gone to a lot of different places. This is the kind of medicine that we practice, particularly in primary care. We're past the era of the doctor knows everything and the patient does what they say. That's not what it is. But this makes it much more complex and difficult. So here's a little example. I've taken this largely from a little paper we wrote about how you think about rational approaches to setting up a clinical practice to optimize preventive care. So this is not actually a really implausible scenario. So I want you to all imagine you're a family doctor and you have Nadia, a patient. So she's 60, she smokes, she's had a cholesterol test done and it shows abnormal results. And you notice, because you've got access to her records, you're saying, okay, she hasn't had a pap smear for a while. You don't really have a blood pressure measurement for her. Oh yeah, we should be doing diabetes risk assessments. That's a bit out of date there. And she's eligible for breast cancer screening. Would she want to do it? She's eligible for colon cancer screening, and she probably will meet the criteria for actually having CT scan screening for lung cancer. There are 8 separate potential preventive actions and strategies embedded in all of this, and for which there are guidelines, that are produced, by the Preventive Services Task Force or by other kind of major organizations. You've probably got maybe a 10-minute consultation, 15 minutes if you're lucky. And the fact is, if you haven't had all of these things, if you've not seen her for 4 or 5 years, whatever, she's probably not someone who comes to the practice very often. What is it that's going on here that's brought her to you? So I have no idea where you would start with her. But where you would start is where she needs to start. And you need to understand her life, where she's at, how easy it is for her to come to see you, and what scares her the most. what bothers her the most. So I hope you kind of see that what we have now when it comes to patient care, and whether it's to do with screening and preventive care or more generally, it's about collaboration, it's about shared decision making, and that means that it's about values and preferences. But it has to be individualized. So evidence is critical, but it's insufficient to give you a starting place. And decision making in this context is not a kind of discrete thing that happens on one office visit. Why am I talking about this? I'm talking about this because I want to underline that there may be ideas that we have about it's obvious you should do these things. People should have screening. You know, people should have a cholesterol test. People shouldn't smoke. People should do this. And it's the job of us in healthcare to sort of guide them towards this enlightenment if they didn't know it already. But in fact, that's not how it works. It's really messy. It's the messiest end of things, but it's actually what healthcare is really about, because healthcare isn't just technical. It's actually, healthcare is a social good. So I'm going to park all of that. But a lot of that flavor. So one thing is, one message from this is that physicians, particularly who work in healthcare, in clinical care like this, may be really, really, really good as doctors, but they may not understand how to stand back from all of that and think about policy decisions, because policy decisions, you're actually having to say, this is what we need to do for the population as a whole. Okay. So you have to, and your priorities for the population involve trade-offs, whereas when you're in with an individual patient, you have to do the best, and your ethical duty is to do the best for that person in front of you. And it's as if everybody else in the world disappears and you deal with them. At the policy perspective, you actually have to think about everybody and all of the competing things that go on. And it's a very different way of thinking. And not everybody gets that. And particularly not all doctors and healthcare professionals get that, but they're often called on as experts to make health decisions. But they may not be wired to think in that way. So policy decision making, let's think about health policy. So I'm going to come to the level of the province. Amy, you talked about the Public Health Agency of Canada and advising at the federal level. And that's part of the, I think, the mosaic of how we think about healthcare. But most healthcare delivery is the responsibility of provinces. And so it's actually kind of helpful to think about that. That's where a lot of the decision making happens. So let's kind of Newfoundland and Labrador. Let's talk about the policy perspective. So on the one hand, you know, the province is responsible for making sure that health services are provided. Hospitals are there. So we've had a recent reorganization. What was 4 health authorities is now one unified health authority called NL Health Services as of this year. So they're responsible for making sure the buildings are there and that they're maintained, that they're staffed. And we know that, you know, staffing healthcare professionals is really difficult. That they have all of the resources, they have the labs, all of this kind of stuff. They have the policies. And these are complex organizations. So that's one kind of policy decision making that's going on. And if I was, for example, David Diamond, who is the Chief Executive Officer of NL Health Services, what's he thinking about? He's the one who's kind of driving stuff. He's kind of working policy on the ground almost as it is. Like, are the services working? Are they doing what they should be doing? You know, if we've got a new CT scanner, so is it, you know, I trust that it's working properly. Are we getting the patients through, you know, is there a backlog? Do we have enough staff for it? Are we using things safely? All this kind of stuff, the day-to-day running of stuff, but also where is this all going? And so for example, within all of this, there's a group that makes decisions about if someone wants to order to bring forward a new lab test. We want to test for this new biochemical marker X. We've never used it before, but it's going to help us treat people with suspected heart attacks much more effectively. We need to know, can we fit that into the lab? Do people need to be trained to do it? Does it mean buying new reagents? Is it going to be cheaper to do than what we're already doing? Are we going to do it in addition to what we're already doing? What's the actual benefit compared with what we're already doing? There's all sorts of stuff. And then equity is about fairness and access. If this is a really good thing, are we going to make sure that everybody has it's available to everybody? How do we, does it need specialized lab staff? Can we put it out in rural areas? You see where I'm going with this? So that it's messy, but here are the kinds of things that are going on in that thinking about how you actually deliver, plan, and move forward with a health service. And then the other side of the slide, and these things are not in competition, but I've separated them for the purposes of the discussion. So the right-hand side of the slide, what have we got here? We've got public health and population health. So as well as the healthcare facilities and all the things that get done in them, there's the other things that actually determine the health of the entire population. So we talk a lot about determinants of health. Determinants of health are not risk factors. They're the things that almost lay the groundwork for risk factors, if I can put it that way. So what we eat, what we drink, what we know, our position in society, how much income we have, all of those sorts of things and others affect, health is not distributed equally. And the things that make it distributed unequally are nothing to do with the health service usually. So there are actions that governments will take, particularly departments of health in governments, that so the sugar sweetened beverage tax. So obesity and diabetes is a significant problem everywhere, but particularly in this province. So one way of trying to reduce this is to reduce sugar consumption. So that it's a consumption tax. Just nudge people to shift their habits, consume less sugar. It's being done through a law and through taxation. That's not healthcare. That's some of the other levers and tools that they have. So that's a decision that was made, and it's following on from, we know that the same strategy reduces alcohol consumption, it reduces cigarette smoking. So taxation, people don't like taxation, but it's a way of actually shifting people's behavior. Housing, we've had a lot about housing insecurity, about the housing crisis. Precarious housing is associated with all sorts of issues, and one of the best ways of kind of getting people out of a cycle often of mental health problems that lead them into homelessness is, first of all, get them in a house, get them in a home, get them stable, and then you can build everything else, and it allows them to then start to deal with other health issues. Early childhood education helps particularly those kids who are in the most vulnerable families. It puts them on a different trajectory. What's the point I'm making? There's most of our health is not created by healthcare. It's about these broader underlying issues. And that's the responsibility of a province as well, and also the federal government. And decisions get made about actions that are possible. So this is health policy decision making as well, but it's not directly about service delivery in healthcare. The people making those kinds of decisions are thinking about deaths and illness and high level. Births, deaths, infant mortality, deaths generally, so Newfoundland has a significantly lower life expectancy than the rest of Canada. It has more cancer, it has more heart disease, it has more strokes. It really, on pretty much all indicators, it's doing worse. Why is this? Those are the questions that exercise departments of health and, the sort of ministry level decision makers and the people who advise them. Equity really comes up there as well, about the different experiences of different population groups and what do we do about that. So if I kind of go back up for a moment, I'm trying not to turn this into a population health lecture, but it's about the mindset that's there. Childcare education, that one at the bottom, that's been in the news recently, early childhood education. Early childhood education is one, it's not the only one, but it's one of the most significant things that can be done to put people on a track that promotes equity. So it will disproportionately help those who are most disadvantaged, and it accumulates over a lifetime, the benefits. So equity becomes one of those things that really makes life very difficult for decision making, because sometimes the things that you do don't always help the people you really want to help as much as you want to help them. Okay, we'll come back to that as well. Resource use. There's a finite amount of money. You can't just, how do governments get money? Well, they raise taxes, and that's not always a feasible thing to do. So you're working within an envelope. How do you put that to best use? But resources are not just money, they're people. They're the facilities you already have. It's the stuff that's already there. How do you put that to best use? And that's a big part of the decision making too. What do we actually have? What can we bring to bear on this? That the population health level policy making is always naturally going to focus on about preventing, making people healthier and preventing people. It's not so much about what treatment things do we need, it's about how do we make people healthier in the first place. One of the challenges with that is it's a long-term piece. You're going to take 10 years usually minimum to see benefits, and so it doesn't fit with the political cycle. That's a different conversation, different day. And values and stakeholder interests. Everybody has a different perspective on and a different stake in decisions that are made. And there's different kinds of underpinning values. I've got a slide on this and I'll come back to it. I hope you're all with me, you're not falling asleep yet. So what matters in a health policy decision? Let's go back to these. I've kind of boiled it down, I think, to sort of these four main kind of considerations, which are really quite complex, but I want to make sure that you understand what I'm talking about in these, because this is inside the brain of a decision maker. So effectiveness is about things actually working, doing the things that they're supposed to do. So in a decision context, it's about, the thing I'm deciding to do, which option, will this option actually make a difference? Will it reduce deaths? You know, it's the evidence piece in a way. That is always going to be sitting there front and central. And what are the harms or other consequences of it? So effectiveness is about the ability of the thing that you do, the decision that you make, the option that you choose to actually achieve what you think it's going to achieve. It seems so obvious, but it's not always articulated explicitly. Resources. Resources are about costs. They're about money, but they're about human resources. And it's often, as I alluded to, it's about where we're going to find this. Is this about reallocating what we have? Are we going to have to find new money here? That's a sort of, it's the sort of practicality of it. It's not about we don't want to spend money. It's about how are we going to do this? What are the implications? What are we getting ourselves into? I want to kind of just take a slight diversion into thinking and trying to see what how complicated this gets, because you'd think, well, here's this decision, we'll do that, we'll bring in this new option, we'll do this thing differently. It's obviously better and we'll find the money somewhere. You can't think like that. So let's just do this. This is very simple, but let's imagine a situation where we have a new policy. We're going to do a new thing. We're going to bring in, for example, we have the option to purchase a new drug that we're paying for, and we're going to compare it with the old one. Let's just kind of put it in those terms. So we've got all these possible options. So compared with what we already do, this new way of doing things, this new drug, the outcomes, so we're talking effectiveness here, the outcome could be the same as what we're already doing, or it could produce more benefit, or it could produce less benefit. Okay, so it's a comparative effectiveness thing. And then there's the cost. It could cost the same, it could be cheaper, or it could be more expensive. So if you follow through that, you could start to populate the little matrix there. So your decision with these, this is where you'd say, yeah, this is a no-brainer. We should shift. All other things being equal, and if and let's not worry about feasibility and equity stuff. Let's just kind of say it's a straight comparison. So if you've got something that is more effective and cheaper, yeah, you're going to go for it. It's more effective and costs the same, you're probably still going to go for it. If you get the same benefit but it costs less, you're probably going to go for it. Now the thing about spending, about costs, is that costs indicate resources that you're using. And if you're using them for one thing, they're not available for something else. So it's not just about finding money, it's about saying, this is worth doing because it's going to, it's the best use of these resources. We're going to get the most from these resources. The other end kind of makes sense as well. So you would never, it costs more and it's less effective. Well, why would you go for it? It costs more and it's the same. So at that end of the table, clearly, that's a fairly clear-cut decision. But of course, most decisions don't fall there. They fall in that line there. If it costs the same and the outcome's the same, well, would you shift? Well, there will be costs to shifting. So you might not, but you might have a lot of, people like new things. No, we want this new drug. What about if one of the most difficult ones and most commonest one is you get something that is more effective, but it costs more. Okay, what are you going to do in that situation? It costs less and there's a bit less benefit. So you get into these sort of gray areas where all sorts of other things are going to play into the decision, particularly. So this is by way of saying, rational decision making isn't usually all that easy because it can't be driven by simple data. There's often other things coming into it. Now, I've set this up as benefits times costs. If I just shift that to harms, it's the same argument. If we want to kind of take the money idea out of this and say, it's the same. It's the same kind of comparison. So what was that all about? That was all about me saying costs, resources to be used and effectiveness. You tend to bring those you have to bring those together, but it doesn't always lead to a very clear-cut guidance to what the decision should be. So these other things start to come in. Stakeholder perspectives are really important, and it's not just about politics. It is about, the principle that particularly when in sort of public policy decision making, beyond voting in elections, actually lots of people have a right. People have a right to have their perspectives reflected in decision making and to be listened to, even in the end of the decisions get made against what they would want. So decision makers are thinking about who are our stakeholders, who cares about this, who has a stake in this, which of these groups actually matter, who's going to make the biggest fuss. I mean, that's a very cynical approach to it, but it's truth. How do we handle it if we have, pardon me, if we have people who have very opposing views? We can't necessarily make a decision that goes down the middle. We have to go to one or the other. How do we do it? So, for example, I've been watching the media around the opiate drug toxicity problem, which has always been there, but has really come to the fore in this province recently. And I was listening last week, parents and relatives and loved ones of people who've died from overdoses on the doors of the Confederation building, shouting about we need something done. And the discourse moved from we need something done to sort of views within that. So you've got one camp that's saying we need a mechanism to force people into rehab even if they don't want it. And you've got another group saying You can't force people into rehab if they don't want it. It undermines their autonomy and their right to make their own decisions. Or it's going to kill people because they're going to come out of rehab, they're going to be all detoxified, and so, you know, their tolerance is going to be low. So you see, those are two different kind of stakes, two different perspectives. Now, some of that might be amenable to evidence, but some of it isn't. It is about fundamental ideas of what should we be allowed to do. We need to protect people from themselves, you know, or no, people have the right to make harmful decisions for themselves. These are two different, very different perspectives. Okay. So there's all kinds of stakeholder perspectives come in. I am not going to be on for 40 minutes the way I'm going, so I'm talking too much. And equity is about fairness. It's about who benefits, who suffers. It's not about equality so much as it's about fairness and how do we reduce unfairness. So I'm going to quickly go through this example. I want to show you how complicated this gets. So we all agree smoking's bad. So let's imagine a hypothetical policy decision to say, okay, we want to reduce smoking even more. So imagine the provincial government's doing this, and we already have stuff in place. So we've got education and smoking bans and consumption tax, all this kind of stuff. We're using a lot of the tools, but we want to do more. We've got some options. We could actually pay for nicotine gums and patches, you know, so where people have to pay for these now, we can make them free. We could actually pay for free counselling for people who are trying to quit, or we could actually, you know, basically subsidize vaping. We could make e-cigarettes available for people who are trying to quit. Actually, there's data on effectiveness for these. It's not 100% cast iron, but it's not bad at all. And it tells us that of all of these, they all work. 4 people out of 100 who are trying to quit will quit, whatever. And you can see there's a hierarchy there. So actually, the most effective, the most likely to be effective is actually nicotine e-cigarettes. Okay, and all of them have a similar low rate of side effects, so that's not it. So all other things being equal, what would you do? What's the rational decision? This is just the evidence base behind it. What's the rational decision? The rational decision is to go for the e-cigarettes. But what about this? What about vaping in teenagers and kids? It doesn't look very good, and we're not doing very well here in Canada. Yeah, but that's a different group. We're talking about smokers, cigarette smokers, and we're trying to get them to stop. So there's the dilemma for the policymaker. At a population level, vaping as a smoking cessation intervention actually would be the best way to pursue that goal of reducing smoking, reducing deaths and illness and healthcare spending on that. And when you don't have to spend your healthcare dollars on one thing, it's available for other things that we need to do as well. So it's a good thing to do. But that means we're normalizing use of vaping, okay? And that will probably normalize it even more, perhaps, in young people. And it looks like there are real harms in young people. So reducing harm in one group, people who already smoke, who need to try and quit, may increase harm in another. How do you square that circle? That's not an easy decision to make. And that's actually a real example. More generally, any kind of smoking cessation intervention, smoking rates are higher in people who have lower incomes, for example, and other disadvantaged population groups. And people in those groups who are smokers are likely to have worse health effects from the smoking anyway, because they generally have worse health anyway. They use healthcare less often. They have poorer outcomes. They're more likely to die. So they're already doing a lot worse. And they're less likely to be able to access or use healthcare smoking cessation interventions. So if you actually do something for any kind of smoking cessation intervention, something to help people quit smoking, and you just roll it out on a population level, the people who benefit the most are going to be those who already probably don't need it so much. It's going to be the higher income, better educated people. So it will reduce smoking rates more in that group, and it's probably not going to have the same effect on income restricted groups. So the effect at a population level is to increase inequality, increase inequity. Okay, so smoking cessation, at a population level, introducing these will help population health overall on average. But in fact, it's working to make equity worse. Now, this is horrible if you're a decision maker, but it's real. This is the kind of stuff that can go on, and it's very non-intuitive as well. So you then kind of resort, and I'm kind of skipping over values, and I'd really like to talk about these, but values actually are often what drive decisions. Generally, avoiding harm should be more important than doing good. That's, in the ethical principles, first do no harm, then seek to do good. But that feels that's a strange one. Do we value individual autonomy, or do we lean towards kind of collective responsibility and looking after each other in solidarity? Where do we sit on that? Justice and equity underpin things, but putting these into practice is very difficult. And I put trust, I just put it there at the end. I'm saying trust is a huge thing in all of this. Trusting, decision makers want to feel trusted. They want to be seen to be making decisions that people can trust. But we also, in the end, an awful lot of whether decisions succeed or not are to do with whether we trust those. I'm not sure I said that very clearly, but we can discuss it. I'm going fast now, sorry. Contextual factors. So we've got all of those things coming in, and there's more. Decisions are always made under conditions of uncertainty. There may be some urgency now, but rarely is there, we have to make the decision this day, this week. It's really, really super emergency. Often it's about, we have to make this decision in the next 2 months, but it's going to take 6 months to do the kind of evidence work. All right, there's a mismatch there, and the time frames that people are using, the decision makers need to make a decision a lot more quickly than scientists can generate the evidence that's needed, and that is a significant issue. And then the consequences of a wrong decision. So we'll come back to those. I'm going to talk about complexity and limitations in a moment. So when you have this kind of combination of uncertainty, you don't have the science, you don't have the scientific evidence, you have a decision that needs to be made fairly quickly, and there is a risk in doing nothing. Not making a decision is an action. Then you're kind of in the territory of the precautionary principle. And that's, the precautionary principle was probably first articulated in relation to environmental risks, but it really came to the forefront in Canada, particularly with the tainted blood tragedy. When the Red Cross used to run the blood transfusion system, and they waited and waited and waited and didn't bring in policies about how to handle HIV and hepatitis C potential contamination of blood. And by the time the evidence was there, it was kind of too late, that a lot of people had been infected, and it led to deaths and avoidable mortality. The Kruger inquiry into this kind of said, you can't do this. The precautionary principle should apply. It's why the Red Cross don't run blood transfusion anymore in Canada, okay? It was all dismantled and set up as a new organization. So the precautionary principle is not an ounce of prevention is worth a pound of cure. I've heard it expressed that way, and that's not what it is. It's about saying, if the risk of doing nothing might cause considerable harm, and you don't really know, but the potential is there, then you have to do something, even if you don't have the evidence to do it. That's the kind of idea. So don't wait for the science. Make the best decision to protect people that you can, and until the science is there to clarify it. Okay, that's the precautionary principle, and it's a legal principle, but also a kind of a decision-making principle. And we saw it with the COVID-19 pandemic. It was part of the defense, and I don't know whether, Amy, you've talked about this, but there's a challenge, a constitutional challenge to what Newfoundland did and Labrador did during the pandemic to restrict entry to the province. And yes, the court upheld that, in fact, this was unconstitutional, but it was justified partly on the basis of the precautionary principle. People are really not good at making decisions. I'm one of those people, I believe if I buy a book and I put it on the bookshelf, then I automatically have everything that was in the book comes into my head and I don't necessarily have to read it. I'm sure there are other people like that too. But this is one of the few books I have actually really read in depth, and it's not a fast read, but if you don't know it, go look it up because it's absolutely astonishing. People are not very good. Our brains depend on heuristics, on shortcuts, and so we make leaps that we shouldn't make. Now, rather than kind of go through all of these, I actually have here, I printed out, I've got a list of hundreds of cognitive biases that come into decision making. Rather than go through all of these, if we've got time at the end and people want to say, okay, what is the such and such bias, then we can go back and discuss them. But my favorite is, of course, the Dunning-Kruger effect, which, to paraphrase, is stupid people are so stupid they don't know how stupid they are. In other words, we're not very good at knowing the limitations of our own understanding. Hope I haven't misrepresented that. But there's many things. Sunk cost. We've invested so much in doing this, we have to keep going. Okay. The gambler's fallacy, the results of previous bets are going to influence the likelihood of a future bet. I mean, really. And the world's not simple. An org chart, the world's full of org charts, and it says this is how the world works. Now, what org charts do is they tell us kind of how, governance and how authority is supposed to happen. But this is the reality, and you may or may not laugh at it, but this is a representation of a complex adaptive system. It's got feedback loops, and when you perturb one part of it, lots of other bits change, and you've got actors in it, people who are unpredictable, and they form alliances and they make decisions, and all sorts of things go on the ground that you don't know about and you can't control for. I can, send people a copy of this and make a link to this. If you're interested, complex adaptive systems. If you want to understand healthcare, I think this is really worth a read, because it's about saying, in some ways, things are so complex, we cannot possibly really get our heads around all of it. And what we do is that we oversimplify and we get into linear thinking, and it leads us to make errors. But there are ways in which you can kind of go back to first principles, and you can use this to understand how to improve decisions. And I'm not really doing it justice, but it's actually very worth a read. It's in the public domain. But we do tend to oversimplify and make things linear that are not linear. I think that's the point. So last couple of slides. So I've gone through this stuff really quickly, and more quickly than I would have liked to, but maybe one or two things will stick with you and we can talk about them. In decision making, especially in health policy, rationality is a complicated idea because it's not about scientific rationality. There's a sense that tends to underpin it, but it's factoring in an awful lot more. Inevitably, health policy decision making, like all other decision making, is flawed. It has to be, because we're limited as human beings and we can't factor in everything, and we're thinking and working in a context which is very complex and adaptive. So you can't really grasp all of it. So in some respects, all of our decisions are flawed decisions. Policy decision making can't be empirical or analytical, or not only empirical or analytical, because in the end it's a social and an ethical and a sociological process. It's a thing that we try to do to achieve stuff. So it's not a kind of, and I suppose that's a way of saying, maybe AI could help, but it's only going to take us so far because there's a lot of other stuff in there. But, and this is my last slide, truly what I see is setting aside manipulation and lying and, you know, bad faith decisions. Most people are making good faith decisions. They're doing the best they can, and they will always come back. And this is, I see it again and again. There are kind of simplifying ways to do it, and they will always lean on these principles, which is about saying, what's the best bet? If we're going to put our resources towards this, what do we actually think we're going to get? It's the expected benefit for the investment. And you can call it value for money if you like, but I want you to see that that's a broad idea. It's about feasibility. Can we actually do this? How much is it going to take to do this new thing, to follow through on this decision? It's about balancing stakeholder interests, but perhaps being seen to listen to everyone, and to balance them as far as it's possible. Okay, so it's not about compromise necessarily, it's about seeing to listen to everyone. It's about equity and it's about fairness. That always plays in as far as that's possible to do, and concordance with values. So this always ends up being about what kind of people are we, what kind of culture is this, what kind of society is this, what is important to us. And what's important to in places like this, particularly in Canada, is it does come back to equity and fairness and looking after each other. But there's other things that creep in as well. So the values piece drives it, and it's never about data so much as it's about, is this who we are? Is this decision reflect who we actually are? And I think I've managed to bring it home. Not quite 40 minutes, I'm sorry. But if there's any time, I'd be very happy to have a conversation. There we are. And I can see you clapping, even if I can't hear you, Joseph.
Thanks so much, Brenda. Were there any questions from anyone? I can start with a comment maybe and just hear I guess you can only see the top of my head. Can you hear me, Brenda?
I can hear you. I can't see you, but I can hear you.
No, I know. I'm yeah.
But I can see the lovely audience. Yeah.
Not all of it, actually.
Some of it.
Yeah, so something I was gonna say is maybe for students, like, this can seem sort of overwhelming, that you can never really solve a problem or solve it well because it's so complicated. And when I teach mathematical modeling, a lot of times I find like the students are really nervous to start because they can just think of so many ways that they can do it wrong and that it's never going to be perfect, and they're just paralyzed by that, being overwhelmed with that. And some of the advice that we often give is, start trying to solve a problem, maybe solve a simple problem, come up with a conclusion, and then think about why it's wrong and how you can improve it, and keep going like that. And maybe with some of these things, I think towards the end you said that, you can never really come up. You have people involved and people have values, and, you want to respect who people are. I guess maybe one of the ways that I would try to handle that in my research would be to do some modeling to come up with a conclusion, but then in the discussion of the paper, start talking about some of these additional complexities that might make it very difficult to know exactly what to do with the information in terms of making a decision either way. So I guess I'm wondering, like, what your advice would be for modelers or for students, in terms of just how to handle everything that you've talked about, because it is, like you said, really, really difficult to address, and you will never be able to address all of these things. So yeah, can you just comment on my long flow of consciousness?
Yeah, sure. And if we're talking about simplification, what's the main message of what I just told you? Decision making is really messy. It's really messy and it's not perfect. So what you're talking about is a kind of like a specific case of what I'd say is a kind of a broader issue. So the area I work in, you might call it very applied health research. In other words, what we're trying to do is do research the results are going to be used. They're actually useful and fairly close to being applicable to real world, as far as you can do that. In that, the best thing you can do is actually, well, a few things. One is appreciate that people are not trying to make perfect decisions. They're just trying to make better decisions than they otherwise would do. So they're more informed. They're more likely to be kind of good decisions, ones that are going to pan out. Understanding, it's almost like start at the end. It's less about the kind of the actual stuff you do than about understanding what's the decision, how's this going to be used, and what do people really need to know, and where's it going to factor in. So there's a whole kind of, area, or approach. It's called, well, there's different versions of this, but one version is just called knowledge co-creation, which is, if you're planning, yeah, I see some nods there. If you're planning a project or you're planning a piece of research which you really intend, you work with the people who are going to use it right from the start or as close to the start. So they're kind of helping you shape the way you approach it in the first place. And it does kind of two things. One is it probably gives you a bit more insight. It may help you make some decisions about what's in and out of the model and things like that. It helps you focus that and frame it. But it also means that you're forming a relationship with them where you're kind of starting to get them, but they're also starting to understand you. So it starts to build that kind of trust piece as well, that it makes it more usable. But the empirical evidence seems to show that research like that is more likely to actually, then the results are taken up into practice. It's actually used. It's more likely to actually be used. So particularly some work, quite a lot of work out of Australia has shown this. And it kind of is obvious when you start thinking about it. The researchers and the users work together. Duh, it is quite simple, but it does seem to work. And I think it's because folks are not kind of working across purposes. Something else I would say, when you're doing a bit of work to that's intended to kind of be used by people, it's not an exam. You're not writing a thesis. It's not an exam, and people are not going to come and say, well, you didn't specify that model parameter quite precisely enough. They're never going to do that. They're kind of thinking about, well, did you take into account that men are different from women? They're going to ask kind of simpler things. And it's not an exam. They're not expecting perfection. They're just wanting something more than they already have. So it's incremental. Does that make sense? Yeah. You still there, Amy?
I am. Yes, I saw some nods with your answer. Did anyone have a question? Francis had, and I think let's come up the front and stand where I'm standing, and you can ask your question to the audience, but I think Brenda's hearing it fine when I'm talking from here. So is this working okay, Brenda? I think I see it. Thumbs up. Perfect. Great. Okay.
Hi, Brenda. Can you hear me? So it looks like the law always wins when it comes to policy decision making. So we as modelers or scientists, is there anything we can do in order to maybe incorporate some of these things which we think we can't actually capture? Like, for example, she was giving an example whereby, when it comes to, let's say, even the COVID, when it came to the restrictions and all that, the law says something different. And then the health professionals also feel this is what needs to be implemented. So what do we do in order to actually lean towards incorporating some of these things, like law and all that, in the kind of models that we build? That's my question.
Okay, I was catching most of that, but I may not have caught all of it. So can I just check that I heard it right? Did you get to that? Did I hear the word low income in there? And you were talking about trying to get. Amy, can you help reframe the?
Yes, I can.
Yeah, sorry.
I usually I'm not sure I'm interpreting any of these questions correctly. I think Francis' question was about how we include law in models, and I guess if I was gonna consider answering that question, I would probably not go hugely into the space of illegal options. I would probably like mostly stick with legal options. But I don't know, like in terms of, maybe you know this better than me, like, so for the travel restrictions, I guess these aren't actually laws, but there's all the countries that are part of the World Health Organization. And I don't really know that any of the countries were supposed to restrict travel or trade, like based on what was agreed to as part of the World Health Organization.
Okay, I'm glad you did that because I completely misunderstood the question. It was just kind of cutting in and out a bit. Okay,
Yeah.
so we're into the whole world of kind of jurisdictions. Who has, which governments have power to do what things and at what level? Every country makes its own rules, basically. So the travel, so within Canada, so Canada is it's a country, but it has provinces. And so without kind of getting too much into it, certain kinds of travel stuff belongs to the federal government. So people coming in international borders. So you will normally find that across the world. But travel within Canada, we've never really had restrictions between provinces. And so this was, I think, the first time probably that I'm aware of what Newfoundland and Labrador did. It had the force of law. It was something that fell under the authority of the Newfoundland government to do. So there was already kind of a public health law in place, which was a kind of a real law here, and it had provisions under it to do emergency measures. So this kind of came under Emergency Measures Act, but it basically, the province believed it had the power to do this. The court case, actually, one of the things it did was to ask the question, does the province have the power to do this? Is it allowed to do it? So it was constitutional law, and I ain't a lawyer. It was constitutional law. So every country really has control over its international borders. But there may be all kinds of treaties and all sorts of things like that. So what you're getting into, I think I should probably not go too far on this. Sometimes laws are not as clear cut as we think they are, and we kind of get to working out, are they real and are they valid?